Hi, I'm Dr. Zuhaib Ahmed with the Advent Health Internal Medicine Residency Program. Today, I'm going to be presenting a rare case of stress cardiomyopathy associated with multisystem inflammatory syndrome in adults. Multisystem inflammatory syndrome in adults, abbreviated as MISA, is a newly defined condition that is associated with a recent COVID 19 infection. Cardiac involvement is a dominating feature of the syndrome. However, the mechanism of cardiac dysfunction is still unclear. Through our case, we want to propose stress cardiomyopathy as a potential mechanism of cardiac dysfunction in MISA and steroids combined with IV immunoglobulin as a potential treatment option. A 29-year-old male patient who recovered recently from a mild COVID 19 infection presented to the hospital complaining of fever, nausea, vomiting, and generalized abdominal pain for 2 days. Vitals were pertinent for low grade fever, tachycardia, and tachypnea with normal blood pressure. Physical examination was significant for pharyngeal erythema, cervical lymphadenopathy, and a macular rash on the trunk and back. Admission labs revealed neutrophilic leukocytosis, lymphopenia, and markedly elevated inflammatory markers. HIV antigen antibody immunoassay and SARS CoV 2 PCR were negative. Chest X ray was also unremarkable. Blood cultures were obtained, and the patient was started on broad spectrum IV antibiotics as a treatment for sepsis of unknown source. On the third day of hospitalization, the patient developed severe pleuritic chest pain associated with ST segment elevation in the anterolateral leads. As you can see in the EKG here in the presentation, there were no reciprocal changes in the inferior leads. Troponin T and proBNP were acutely elevated. An urgent coronary angiogram was negative for coronary artery disease. A transthoracic echo, however, revealed left ventricular ejection fraction of 40% with no wall motion abnormalities. A subsequent cardiac MRI, as shown in the presentation, revealed mild global cardiomegaly associated with biventricular dysfunction and a normal non enhancing myocardium, ruling out the possibility of myocarditis. Admission blood cultures had no growth, and Carrier's test ruled out the possibility of infections as a cause of patient's symptom. A diagnosis of multisystem inflammatory syndrome was thus made, and the patient received 60 milligrams of intravenous methylprednisolone 3 times a day and intravenous immunoglobulin 40 milligrams per kg for 5 days. The patient also received guideline directed therapy for systolic heart failure. The patient responded well to the therapy with the resolution of inflammatory and cardiac manifestations. A cardiac MRI performed 5 days later demonstrated normalization of ejection fraction and other cardiac indices. The patient was discharged with the tapering doses of steroids. Stress cardiomyopathy is increasingly recognized in association with COVID 19 disease and carries worse prognosis. Our case demonstrates an association of stress cardiomyopathy with MISA and also highlights its role in cardiac dysfunction found in MISA. The prompt response to steroids and IV immunoglobulin makes them a potential treatment option. However, more studies are required to better understand the mechanism of cardiac dysfunction in MISA.